Hello everyone and welcome to our module on clinical trials. So in clinical medicine, lots of the things that we do are based on clinical trials. And so in this video, we'll try to talk about what a clinical trial is and how you can interpret it. To understand clinical trials, we first have to talk about observational studies. These are epidemiology studies like cohort studies and case control studies, which I talk about in detail in other videos. And so in an observational study, researchers have no control over exposure. They can study patients who were exposed to something like cigarette smoking or environmental toxins and compare those patients to others who were not exposed, but the researchers can't control who is exposed and who is not. In contrast, in experimental studies like clinical trials, researchers control exposure. They determine who is exposed and who is not. And the goal is usually to determine the benefit of therapy. So for example, in a clinical trial, some patients might be exposed to drugs and some might not, and you compare the two groups to try and determine if the drug is beneficial. You can do the same thing with surgery and other procedures in medicine. Compare a group that's exposed to the surgery to a group that is not. So clinical trials are very powerful pieces of evidence in support of a therapy, and the reason they're so powerful is because of a couple of features which make the findings of clinical trials very reliable. And the main features that do this are control, randomization, and blinding. Control refers to the fact that in clinical trials, one group receives therapy, this might be a drug or a surgery, but then you have another similar group that receives no therapy. This is called the control group. And then you compare the outcomes in the therapy group to the control group. And this helps you make sure that any changes you're seeing in the therapy group are only present in that group receiving the intervention like the drug or therapy and are not present in a group not receiving the intervention. Beyond just using a control group, many clinical trials assign patients to the therapy arm or the control arm through a process known as randomization. In this process, subjects are randomly assigned to either the treatment arm or the control arm. And if this is done correctly, then all variables other than the treatment should be equal between the two groups. When you randomly assign patients to either the treatment or control arm, you should eliminate confounders because all potential confounders like age or weight or blood levels should be equal in the two arms. The only thing that should be different in the two arms after successful randomization is the presence or absence of the treatment. This not only limits confounders, it also limits selection bias because patients can't choose to be in the drug arm of the study or the control arm. And in most clinical studies, they have what's known as Table 1. And the whole point of Table 1 is to demonstrate that randomization was done effectively. So here's an example of a hypothetical Table 1 from a clinical trial. So imagine we have some intervention, maybe it's a new drug therapy, and we compare a group of patients who receives the intervention to a control group that does not receive the intervention. Table 1 will usually show a number of demographics and comorbidities, like it might show the percent of patients that are male and the mean age. It could show the percent of patients with diabetes or the mean systolic blood pressure. And if randomization was done appropriately and was successful, then the p-value for the comparisons between the two groups should be non-significant for all the variables shown in Table 1. And then blinding refers to the fact that treatment subjects are given the therapy or the drug and control subjects are given placebo, but the subjects are unaware of whether they're getting the treatment or not. If you blind the participants in a research study, then they can't change their behavior based on knowledge of whether they're getting the drug or not because they don't know if they're getting the drug or not. In a single blind study, all the research subjects are unaware of whether they're receiving the therapy or the drug or whether they're in the placebo arm. In a double-blind study, subjects are blinded and so are providers. This way, providers can't change what they're doing based on whether patients are receiving the intervention or not. And then finally, in a triple-blind study, subjects, providers, and data analysts are all unaware of who has gotten the drug and who has received a placebo and is in the control arm. And this makes it very unlikely that any behavioral change based on a subject or a provider or a data analyst could influence the outcome of the study. So an important thing to know about clinical trials is that the best evidence we have of the efficacy of interventions like drugs and surgeries comes from randomized controlled blinded studies. Clinical trials are very powerful evidence in support of using an intervention to improve patients' outcomes. Now, having said that, for lots of the things we do in medicine to treat patients, we don't have clinical trials supporting their use. So you may wonder, why don't we do clinical trials for everything in medicine? There are a couple of reasons for this. First of all, clinical trials take a long time. It can take several years to conduct a large clinical trial of a drug or a surgical intervention, and in many cases, by the end of the study, new treatments may have emerged, and so the study findings are not even relevant anymore. And then associated with the fact that it takes a long time to conduct clinical trials, it also costs a lot of money to pay all the investigators and to recruit the patients and to collect and analyze the data is very, very expensive. So there are many things we do in medicine without clinical trial evidence that they work. We have other weaker evidence supporting the use of these interventions, but we don't have clinical trials. Another reason we don't have clinical trials for everything we do in medicine has to do with what's known as the parachute example. So a joke in clinical research is that there is no clinical data showing that parachutes are effective compared to placebo. Now obviously parachutes are very effective, and we would never do a clinical trial where we would push someone out of a plane without a parachute to see if they did as well as the person with a parachute. But the point is that there are certain circumstances in medicine that are so dangerous that we treat patients even though we don't have clinical data, because it would be unethical to deny them that treatment as part of a study. So for example, in a patient with massive hemorrhage, we administer fluids and blood products. We would never have a randomized trial where we would assign someone to a control group with massive hemorrhage who doesn't receive fluids or blood products. It's simply too dangerous to do that, and we have enough evidence that the therapy works without needing randomized clinical trials. Let's talk about some of the ways that data from clinical trials can be reported. So let's suppose that drug X was given to patients, and the patients who received the drug had a 30% mortality over 3 years. In the control arm, patients received a placebo, they did not get drug X, and there was a 50% mortality over 3 years. So one thing clinical trials do is simply report these numbers along with a p-value for the comparison. But there are some other ways that it can be reported, and they're shown on this slide. One is the absolute risk reduction. This is 50% minus 30%, which is 20%. So a clinical trial like this might report an absolute risk reduction for drug X of 20%. You can also report the relative risk reduction. So the relative risk reduction is the absolute risk reduction divided by the risk in the placebo arm. And so in that case, this works out to 40%. And in many cases, the relative risk reduction is larger than the absolute risk reduction. Suppose, for example, we had a clinical trial where the absolute risk reduction was 5% minus 3% or only 2%. That's a very small number. But if you do the math, the relative risk reduction in this example would be 40%, which is much higher than 2%. And so because the number is bigger, people like to report it to give an idea of the magnitude of the change relative to the risk in the placebo group. Clinical studies also like to report the number needed to treat, so let's talk about that now. So once again, let's presume drug X had a 30% mortality and the placebo group had a 50% mortality. The number needed to treat is the number of patients who need to be treated to prevent one adverse outcome. In this case, the adverse outcome is mortality. And you can calculate the number needed to treat by taking 1 and divided by the absolute risk reduction. In this case, it's 20% or 0.2, so the number needed to treat is 5. And this means that 5 patients need to receive drug X for 1 death, 1 mortality over 3 years to be prevented on average. And just to make this more clear, here's an actual clinical study from the New England Journal of Medicine in 2019. This was a study in heart failure patients who were randomized to either receive the diabetes drug dapagliflozin or a placebo, and the results from the 2 different groups are shown here. The primary endpoint for the study was a combination of cardiovascular death or hospitalization for heart failure, and I'll talk more about combined endpoints in just a minute. You can see that in the dapagliflozin arm, 4.9% of patients had the primary outcome, and in the placebo group, 5.8% of patients had the primary outcome. And so that's a difference of about 1%, so the absolute risk reduction would be 1% for this study. And then if they asked you for the number needed to treat, it would simply be 1 divided by 0.01, and that works out to 100, so the number needed to treat for this clinical study would be 100. So any chance you get to look at actual clinical trial data like this during your training, you should take advantage of that and learn to be able to pull out the numbers from dense slides like this so that you can identify the absolute risk reduction, number needed to treat, and other things that they might ask you about in your board exams. Now let's talk about the interpretation of clinical trial results. There will be lots of questions about this on your board exams. They want to know if you can determine the significance of the findings in a clinical trial. And some of the questions you should ask yourself to determine the significance are shown on this slide. First, is the result of the clinical trial clinically meaningful? Suppose, for example, a drug reduced blood pressure by 2 millimeters, and the p-value for this change was significant. But the average hypertension patient is 15 millimeters above their goal. What this means is that even though this clinical trial found a significant result of a reduction of blood pressure by 2 millimeters of mercury, the drug is not going to be very useful clinically because patients need to come down by 15 points. And so lots of questions around clinical trials have to do with, are the results clinically meaningful and will they have benefit to actual patients in actual practice? Another important question is, was the population representative of actual practice? Earlier we talked about Table 1, which describes the demographics and comorbidities of clinical trial patients. You always want to ask yourself, are the characteristics described in Table 1 of a clinical trial similar to actual practice? If the patients in the trial are much older or much younger, or if they're much healthier or much sicker than actual practice, this could make the results such that they don't apply to actual clinical practice. And then you also want to always ask, did the drug or the intervention studied in the clinical trial change a meaningful outcome? For example, imagine a study showed that a drug reduced biologic activity of cancer cells, but there was no change in mortality between patients who took the drug and those who didn't. This implies that even though the trial has some effect on cancer cells, that effect is not beneficial to patients because it's not changing mortality. There's something else going on here. So you always want to look at the outcome from a clinical trial and ask yourself, is that meaningful to patients? Is that outcome something like myocardial infarction or death or hospitalization or some outcome that really matters to patients? Or is it a softer outcome that has to do with something like cells in the body or the levels of a substance in the blood? And so this brings me to an important point on interpreting clinical trial results, and that has to do with the outcomes that are studied in the trial. So in a clinical trial, you typically have an intervention group that receives a drug or a surgery or some other medical intervention, and you compare the outcomes in that group to the control group. Well, one of the major decisions you have to make when you're designing a clinical trial is what outcome are you going to assess to compare the two groups. This is also sometimes called the endpoint of the study. What endpoint are you going to assess in the two groups? You could assess the rate of death in the two groups. You could assess the degree of pain. You could assess the blood pressure in each group or the serum cholesterol in each group. Whatever you choose, that's the outcome or the endpoint of the clinical trial. And this is a major element of interpreting the study results, the endpoint that is chosen and the findings that the study has in relation to that endpoint. Let's talk about some of the different outcomes that can be evaluated in a clinical trial. Continuous outcomes are outcomes that exist on a continuum. Basically, these are outcomes that you can assign a numerical value to. For example, blood pressure is a continuous outcome. So is total cholesterol, so is body weight. And when clinical trials use continuous outcomes as an endpoint of the trial, you compare the mean values between the two groups and you look for statistically significant differences. In contrast, a categorical outcome is an outcome that exists in a category like yes or no. For example, death is a categorical outcome. Patients can either die or not die, but you can't assign a numerical value to this outcome. Other categorical outcomes are hospitalization, stroke, myocardial infarction. You can even convert a numerical outcome into a categorical outcome. For example, if you say patients who have blood pressure less than 140 are in one category and above 140 are in another, you've now converted blood pressure into a categorical outcome. And when clinical trials use categorical outcomes, they compare the percentage of patients in each group who has the categorical outcome of interest. You can also classify the outcomes in clinical trials as soft or hard. So a soft outcome is something like quality of life or reduction in pain. These things are important to patients, but they're not directly harmful. In contrast, a hard endpoint is something that is directly harmful. So for example, hospitalization for a serious medical condition is a hard endpoint. So is stroke, so is myocardial infarction, and so is death. All of these things are significant events in the lives of patients that are directly harmful, and so they are called hard endpoints. Surrogate outcomes are a subtype of soft outcomes where the outcome is predictive of a hard outcome. So for example, systolic blood pressure can be a surrogate outcome for stroke. It's not the same as measuring a hard outcome like stroke, but the higher your blood pressure, the higher your risk of stroke, so it functions as a surrogate outcome. By that same logic, hemoglobin A1C level can be a surrogate for diabetes complications. The higher your A1C, the more likely you are to develop diabetes complications. Researchers like to use surrogate outcomes because they're easier to obtain. If you're monitoring a population of patients for stroke, it may take many years for patients to develop stroke so that you can compare different groups. On the other hand, it's very easy to obtain a systolic blood pressure on every patient in your study anytime you want. The disadvantage is that surrogate outcomes sometimes lead to erroneous findings. There are examples in medicine over the years of interventions that seem to work based on surrogate outcomes, but when someone finally did a clinical trial using a hard endpoint, the intervention did not have a significant effect. All clinical trials have one outcome that's called a primary endpoint. This is the outcome the study is designed to evaluate, and researchers use this endpoint to determine the power of the trial. The trial power is what determines the sample size that's needed in order to conduct the clinical trial. So for example, if your primary endpoint was going to be the rate of myocardial infarction in the two groups, then you would use the anticipated rate of myocardial infarction to design your trial and determine how many patients to recruit. And therefore myocardial infarction would be the primary outcome or the primary endpoint of the study. Some clinical trials also have secondary endpoints or secondary outcomes. These are outcomes of interest, but they're not used in the power calculation and they're not used to determine the sample size for the study. So anytime a clinical trial reports a secondary endpoint, you have to interpret these findings with caution because the study was not designed to detect differences between groups in the secondary endpoints. So that brings me to an important point about negative clinical trials. This occurs when a clinical trial finds a difference between groups that is not statistically significant. So imagine we had a trial with two groups, Group A and Group B. Group A received a cancer drug and Group B received a placebo. And let's imagine we studied these patients for 3 years and we compared the rate of death, and there was no significant difference in the rate of death between the two groups. One explanation for these findings is that drug A simply doesn't work. But you also have to consider the possibility that the power of the study is what caused the clinical trial to be negative. The power of a study is the chance of finding a difference between two groups when one exists. You can also think of it as the chance of rejecting the idea of no difference between groups because there really is one. And I talk in other videos in more detail about the concept of the power of a clinical study. But what you always want to remember is that power increases with sample size. So if you have a very small study with a very small sample size, this study could be underpowered, and that means it's not able to detect small differences. And what this is really saying is that the p-value is going to be non-significant if the true difference between the groups is small. So going back to our example of Group A that got the drug and Group B that got placebo, well, if the difference in mortality between the groups was huge, like for example 1% in Group A and 50% in Group B, then we could find a statistically significant difference between groups even with a small sample size. But real life hardly ever works out this way. In real life, the kind of differences you might see between the groups might be something like 1% for Group A and 1.5% for Group B. This is a very small difference, and if this is the true difference in reality, you're going to need lots and lots of patients and a large sample size to find a statistically significant result. So the take-home point here is that when a clinical trial is negative, you have to consider that it could be because the intervention you were studying is not useful and doesn't help patients, but it also could be because the study was underpowered and that the sample size was too small to identify a statistically significant difference between groups. Some clinical trials also use what's known as a combined outcome or a combined endpoint. This is often done in trials that have categorical outcomes like death or myocardial infarction or stroke. And to understand why combined endpoints are used, let's imagine that a trial was conducted of 2,000 patients and the endpoint was death. Well, for most diseases, patients don't die very rapidly, so after 2 years, you might only have 5 total deaths among all the 2,000 patients in the trial. And when the number of deaths is this small, the difference between groups is not going to be significant. So when you get a finding like this, that the difference is not significant, you won't know whether it's because your intervention doesn't work or if it's just because you didn't allow enough time to go by, and that if 8 years or 15 years went by and you had more people die in both arms of the study, then you might find a significant difference. Now consider what would happen if the same trial of 2,000 patients was done, but instead the endpoint was the rate of death, hospitalization, and stroke compared between the intervention and control groups. Now, after 2 years, you might have 375 endpoints because the endpoints are a mix of all these different things. And when you have 375 endpoints, now you have enough outcomes that you can draw some conclusions between the two groups. You might find a significant difference between the two groups with this many endpoints, or if you don't find a significant difference, you can believe the result because enough outcomes have occurred in the two study populations. So combined endpoints are very popular in researchers conducting clinical trials because they allow for faster studies. If you use a single endpoint like death, you might have to wait 5 or 10 years for enough people in the two arms of the study to die so that you can draw a conclusion. On the other hand, if you use a combined endpoint, you might be able to complete the study in just 1 or 2 years. And just to make some of these points even more clear, let's go back to this slide where I talked about the study in heart failure patients who were randomized to receive either dapagliflozin or placebo. First of all, notice that the primary outcome was a combined endpoint of cardiovascular death or hospitalization for heart failure. And hopefully you understand now why researchers chose a combined endpoint rather than a single endpoint. Notice also that in the treatment arm, the percentage of patients who had the primary outcome was 4.9%, and in the control group it was 5.8%. This is a very small difference between groups, and yet this study found a significant result with a p-value of 0.005. Well, the reason it was able to find a significant p-value is because it enrolled a lot of patients. Notice that there were 8,500 patients in both arms of the study. That's over 16,000 patients, and that's how many had to be recruited in order to find this p-value, because the true difference in reality is very, very small, only 1% between groups. And so you need a lot of patients in order to find a statistically significant p-value. If these researchers had only recruited 500 patients, they probably would have had a p-value much higher than this, indicating a non-significant finding, and it would have been because they didn't have enough patients to detect the small difference that existed in reality. Some clinical trials are called non-inferiority trials, so let's talk about those now. In these clinical trials, a new treatment is compared to a standard of care, and the goal is not to show that the new treatment is superior to the standard of care, it's to show that the new treatment has similar outcomes to the standard of care. In other words, that it's not inferior. This is used in situations when a placebo group may be unethical. For example, if the standard treatment is well established and highly effective, it's not ethical to compare the new treatment to a placebo group where patients get no treatment at all. Non-inferiority trials are also done when the improvement with a new therapy may be very, very small, and it would take thousands and thousands of patients to show that the new treatment is superior. Instead, researchers will set out simply to show that the new treatment is not inferior to the standard of care. The way non-inferiority trials are designed is by choosing a difference in outcomes that is considered acceptable by researchers. The null hypothesis is that the difference between groups is greater than this acceptable difference. In other words, that one group is superior to the other. The alternative hypothesis is that the between-group differences are less than the acceptable difference. In other words, that there is non-inferiority between the new treatment and the standard of care. And so if you get a p-value less than 0.05, then you reject the null hypothesis and accept the alternative hypothesis, which means that the new treatment is non-inferior to the standard of care. So for example, here's a recent clinical trial in the New England Journal of Medicine which tested apixaban for the treatment of thromboembolism like DVT and pulmonary embolism in cancer patients. It would be totally unethical to have a group of cancer patients with thromboembolism who were randomized to a placebo arm. So instead, apixaban was compared to dalteparin, which was considered the standard of care. The rate of recurrent thromboembolism in the two groups was 5.6% in apixaban and 7.9% in dalteparin, and the p was less than 0.001 for non-inferiority. And what this means is that apixaban is not inferior to dalteparin, and you can use apixaban and expect similar or non-inferior outcomes. Kaplan-Meier curves are a very popular way to show the outcome of a clinical trial, so let's talk about those now. Kaplan-Meier curves are also called time to event curves, and they plot the proportion of patients over time who have not had an event in a clinical trial. So let's take a look at this Kaplan-Meier curve I've shown on the screen here, and let's imagine we have a clinical trial comparing a treatment group to a placebo group, and the outcome is death. We have time along the x-axis, and at time 0, which is the beginning of the clinical trial, 100% of patients are free of death and have not experienced that event. But as time starts to pass, patients start to die in the two different groups. And you can see that in the placebo group, patients are dying at a much more rapid rate compared to the treatment group, and therefore at any point in time, we have fewer patients who are free of death in the placebo group compared to the treatment group. And so this is just a way of visually showing you the outcomes in a clinical trial over time. Hazard ratios are often reported in clinical trials. They are similar to risk ratios, which I talk about in other videos. The hazard ratio is the probability of events in the treatment group compared to the control group. A hazard ratio less than 1 means that the event is less likely in the treatment group, and a hazard ratio greater than 1 means the event is more likely in the treatment group. So this is a slide we saw earlier showing the outcomes in heart failure patients randomized to either dapagliflozin or to placebo, and you can see that the authors reported the hazard ratios. And this is the hazard ratio for the primary outcome of the study. You can see that it's less than 1, meaning that the outcome of the study, which was cardiovascular death or hospitalization, was less likely to occur in the treatment group compared to the control group. Some clinical trials are analyzed according to an intention to treat analysis. What this means is that the subjects are analyzed according to the group that they were originally assigned, regardless of whether they received treatment or not. Let's imagine we conduct a clinical trial of a new surgical procedure for cancer. We assign half the patients to Group A, they're assigned to receive surgery. The other half is assigned to Group B, they're assigned to receive medical therapy. Well, what can happen is some of the patients in Group B can end up becoming very sick and requiring surgery, and some of the patients assigned to surgery may become too sick to receive surgery and they end up getting treated with medical therapy. What can also happen is some of the patients in Group B can die and they never receive the medical therapy, or some patients in Group A could die and they never receive surgery. In an intention to treat analysis, none of the loss of patients to death or the crossover matters. You analyze patients according to the group to which they were originally assigned. So the benefit of this type of analysis is it's not affected by crossover or dropout. Patients in the control group might require treatment. This is called crossover. They're still analyzed as members of the control arm. Or patients in the treatment group may be unable to comply with treatment. This is also crossover, and these are still analyzed as members of the treatment arm. Or, as I said before, patients in one arm or the other may drop out of the study, and they are still analyzed according to the arm they were originally assigned. So the benefit of this type of analysis is it lets you know what would happen if you had a policy of assigning patients to one form of therapy or another. In many cases in medicine, there are treatments that work, but when you assign patients to that arm, things happen, like they die before they receive the treatment or they cross over to another form of treatment. In an intention to treat analysis, none of those things affect the outcomes. You're comparing the groups according to the group in which they were originally assigned. Let me briefly mention meta-analyses. So a meta-analysis is a clinical study that pools data from several other studies together. The benefit of doing this is it increases the number of subjects and controls, and it increases the statistical power. So let's imagine we have a drug called drug X, and we compare it to placebo, and we do a small clinical study, and we find no significant difference in outcomes between groups. Let's further imagine that 4 other small studies are done, and they also find non-significant differences between groups. Well, in a meta-analysis, you could pool all the 5 studies in existence of drug X versus placebo together, and sometimes this gives you enough statistical power so that your finding is no longer not significant, and instead you get a significant difference between groups. The problem with doing meta-analyses is that the pooled studies are not always identical to one another, and they often differ. They may have different selection criteria for patients. The exact way the treatment is administered or used can be different, and so this can create issues with interpreting the meta-analysis that pools all these different studies together when elements of the studies may be different. And then I'll finish this video by talking about how new drugs are approved in the United States. So clinical trials to get a new drug approved for use in patients are done in phases. A phase 1 clinical study involves a small number of healthy volunteers who are administered the drug. And the goal of a phase 1 study is to determine basic things about the drug, like its safety, if it has any toxicity like major side effects, and also things like the way the drug is metabolized and pharmacokinetics. After a successful phase 1 trial in healthy volunteers, you can then conduct a phase 2 study, which is a small study in patients who are sick. In phase 2, you know that the drug is safe, so now you're trying to make sure it's efficacious, meaning it improves disease. You want to determine the appropriate dosing to get the maximum benefit for patients, and once again you want to monitor for side effects and toxicity. And phase 2 trials are often placebo-controlled with a control arm that gets a placebo treatment, and they're usually blinded as well so that patients and often researchers don't know who is getting the placebo and who is getting the drug. And then after a successful phase 2 study, you can conduct what's known as a phase 3 study. This involves a very large number of sick patients. Often it involves many patients at many different centers around the United States. These are always randomized trials, and the goal is to determine drug efficacy compared to placebo or standard care. And once a drug has had a successful phase 3 clinical trial, it's often submitted for approval by the Food and Drug Administration, and if it receives approval, you can then begin administering the drug to patients. And then finally, some drugs undergo what's known as a phase 4 clinical study. This is a post-marketing study. It's done after the drug is on the market and being used. And often the goal of a phase 4 study is to monitor for long-term effects. So the clinical trials used to get a drug approved may be 1 year or 2 years, for example, in length. A phase 4 study might monitor patients receiving the drug out to 5 years or 10 years to see if there are any long-term effects. Sometimes phase 4 studies are also done in different populations than the population that was studied when the drug was approved. For example, if a drug is approved by testing in younger patients, but in clinical practice many older patients need the drug, then sometimes a phase 4 study will be done to see how the drug performs in that different population. And that concludes our module on clinical trials.